Okay, let's go ahead and proceed. Good morning and welcome to today's statewide substance use resource response working group on the subcommittee on prevention. Before we begin, let's go ahead and proceed to call the roll.
All right, Senator Doñate.
Here.
Debbie Nadler.
Present.
Eric Schoen. Jessica Johnson.
Here.
And Senator Heidi Sievers-Gansert.
Here.
All right, Mr. Chair, we have a quorum.
Thank you so much. Seeing that the quorum has been established, let's go ahead and proceed to public comment. So public comment will be received via this Zoom meeting. It should be limited to 3 minutes per person. And just as a reminder that no action may be taken upon a matter raised during a period devoted to comments by the general public until the matter itself has been specifically included in the agenda. So we'll go ahead. If there are anyone on the, if there's anyone on the Zoom meeting that would like to provide public comment, I'd ask that you can either raise your hand, that way staff members can call on you through the Zoom feature. If I see anyone, I can call on you, but I don't see anyone at this time.
I'm not seeing any hands raised either. All right, I see
Nadler.
Debbie has her hand raised.
Ms. Nadler, please proceed.
Yes. Hi, everybody. I'm not sure if this is the time. I've included Joseph Engel on here. I'm not sure he is able to get access. I know he's on here. He was going to do a presentation. Do you remember what I sent in? I sent in the Just Say No, the Art of Communication school program. And he was going to get on and talk about it. And he texted me. I don't think he's in a place. I think he can't speak. I think he was trying to. Is this something I'm able to talk about, or do we wait till our meeting?
Ms. Nadler, so we can only have presentations that are on the agenda. And so if he wants to, he can give a short discussion within a 3-minute period during this time. Otherwise, you can continue with your comments, but it's only limited to 3 minutes. Okay.
I thought this was on the agenda. I had sent it in and I just received it this morning and I wasn't able to open it. If it's not, I had sent it in. Is it on the agenda for school programs?
It's not on the agenda. We have a different presentation item that we can discuss further later today. So if you'd like to discuss, if you'd like to continue with your public comment, I will give you the 3 minutes, but you can say anything you want. But otherwise, if you have deliberation on policies, we can move to other folks that would like to talk.
Okay, and can I talk about the program at a later time during this meeting?
Yes,
would that be a proper?
Yeah.
Oh, okay.
Yeah.
Okay. Thank you.
Okay, let's go ahead and allow other folks as well to do their public comment. I see Joe has his hand raised, so please begin, sir. You have 3 minutes.
Hi, good morning, guys. I am so sorry. I was having a hard time. I'm not in a great place to actually talk about this. And thanks, Debbie, for the nudge to get me to speak at the committee. Thank you very much to the committee for sharing this. It's very important opportunity to really move the needle here in the state of Nevada on how to get these funds for opioid abatement. I just wanted to, ask the committee to consider, when they're considering allocations of funds, to consider the success of certain programs that are already in right now that are happening. My organization, There's No Hero in Heroin, has been a front runner in doing innovative strategies that haven't necessarily been tried before. We've had a record of a very successful record in getting the public aware, raising the awareness of the opioid crisis, which has now transitioned into a fentanyl crisis. And we're starting to see that fracture. So we've developed some prevention programs, and we've been certified by the state of Nevada to offer primary prevention in addition to our peer recovery support services and our clinical outpatients for adolescents, which the state of Nevada is drastically lacking. according to the mental health providers census, we have the lowest in the United States and the whole state of Nevada for access to mental health providers for adolescents. So I believe this funding could certainly help address that issue. And that's all. I mean, I would look forward to being able to give a full presentation if that was available. Other than that, I could be reached very easily. We're online. We're very, very public, and I guess that's about it. Thanks again, Debbie, for the nudge to join this meeting.
Jeff.
Thank you so much for your public comment. Are there any other folks that would like to provide public comment at this time? I don't seem to see any, so I will go ahead and close public comment at this time. Once again, we also have, I believe we have public comment at the end of this meeting. So if there's any other comments, we can come back to them. Okay. Let's move on to agenda item 3, which is the review and approval of the minutes from the May 23rd, 2022 Prevention Subcommittee meeting. At this time, I will go ahead and ask members to review the minutes and to note any changes or corrections. And if there are any comments or questions, we will entertain them now. Otherwise, I will go ahead and ask for a motion to approve from the committee members. So is there a motion from any of the members to approve the minutes from last meeting? From the May 23rd meeting?
Alrighty.
Once again, from any of the committee members, is there a motion to approve the committee minutes? Need to, if someone can raise their hand or show or verbally communicate.
I'll make a motion to approve.
Thank you so much, Senator Ganser. We have a motion from Senator Ganser to a motion to approve the minutes. Is there a second?
Goodness.
I can second.
We have a second from Ms. Johnson. Are there any questions, any discussion on flavor? Please say aye. Aye, or raise your hand from the committee members if you approve.
Aye.
Okay. With looks like everyone's in favor, so the motion passes. Thank you so much. Let's move on to our next agenda item, which is a presentation on school-based resources for behavioral health. Today, we have a presentation from Dana Wilburn, who is a school health services project manager from the Nevada Department of Education. And we also have additional folks to help present on this subject. We have Christy McGill and Dr. Ashley Greenwald from the Nevada Department of Education, who will present with Dana. And following this presentation, we can have questions from the committee members on the subject area, and then I'm happy to discuss any other proposals that may happen. So please proceed. Thank you so much.
Good morning. This is Dana Wilburn. Thank you so much for the invitation to talk about school-based behavioral health. It is near and dear to my heart. I work under Christy McGill, who's joined me for this presentation. It's something we love to talk about, and we believe very much in access for our youth, especially in these upcoming recovery and repair years. So we'd like to talk about some of our systems that we've set up and what we found to be most helpful. So if you can go to the next slide. Thank you so much, Emma, for facilitating this. Quick disclosure, we're presenting on the behalf of Department of Education in the Office of Safe and Respectful Learning Environments. And our partner is also on the call with University of Nevada's Positive Behavior and Interventions and Supports Technical Assistance Center, Dr. Ashley Greenwald. She'll be available for any in-depth questions you have regarding PBIS or an MTSS, which we'll talk about shortly. Next slide. Thank you. So I want to talk a little bit about what's happening in Nevada. It's pretty neat, actually, because there's only 17 other states who have expanded their access with Medicaid to provide school-based behavioral health. So that means that districts or local education agencies may be reimbursed for specific behavioral health services or early periodic screening and testing. It would allow our districts to have a return on investment for providing these services on school site. So Christy's created a team within NDE in partnership with DHHS to provide technical assistance and trainings and guides for schools to build behavioral health systems within a framework. Right now, there are 7 districts in Nevada that have their contract ready for Medicaid. So they've entered into contract with Medicaid and can begin to build this school year. We have partnered and been led through an interconnected systems framework with UNR's team, Dr. Greenwald, for DHHS and NDE to align our policies, our state policies and our procedures when serving youth and families across the state. And this includes schools where kids are at. And so ensuring they can get access to quality, efficient care at school when they need it has been really important. We have been able to pilot an MTSS framework, which we're going to go into more detail what that means and what that looks like in 10 local education agencies. And we're calling that so you know it also encompasses the charter authority. So it's not just school districts, it's the charter authority. What we've found, so we've had 2 cohorts of Project Aware, which is advancing wellness and resilience in education, which is a very prevention focused grant of how do we keep kids out of care and out of long-term care by providing universal prevention. And what we found in the last decade or so is that unless you have a very strong system built to fidelity, you don't have sustainable practices embedded in the school. And so if we just provide personnel, but no system to support that with data decision rules, process improvement plans, you don't have a system that lasts. And so the best way that we found is utilizing and implementing MTSS, which is multi-tiered systems of support. We'll walk that through you, but MTSS best accelerates and maximizes student academic and social emotional outcomes through the application of data-based problem solving and progress monitoring. Next slide, please. What we'd like to do, and Chrissy's going to walk you through this, is really show you the outcomes of implementing a system like this in school districts. Student-specific outcomes. So we'll kind of walk you through that, and I'll pass off to Christy McGill.
Good morning. It's so nice to see some familiar faces on the committee. Very honored to be here this morning. Next slide, please. So a couple of the issues that are facing our schools, I'm sure you've heard in the media that really, I think the pandemic and then also the epidemic around fentanyl has really hit our schools, where some of the hospitals of the pandemic were in the first wave. The second wave really dealt with mental health issues, and that really hit our schools. So we had a couple of learnings from that, what we wanted to share with you today. The first is that many of our school staff felt really overwhelmed by the amount of students needing individual and intensive services. And so what we're really working on in order to facilitate recovery and be able to respond to some of the epidemics like fentanyl is strengthening our universal and preventative measures in our schools itself. We hope, and we've learned through our data, you'll see that today, that when schools are able to do that, the amount of students needing that intensive one-on-one in Tier 3 services actually reduces. And this is really important for sustainability, because as you can see, Nevada, we still are very far from meeting our recommended ratios of school-based providers in our school. Let's just take a look at Clark, for example, and school social workers. So only the state of Nevada took the federal recommendations of how many school counselors, school social workers, school psychs are really needed to make sure that interventions are done well and that teachers are not feeling overwhelmed. So as you can see, Nevada is really low on meeting those ratios. I just gave you an example here of school social workers. So what's happening now, again, is forcing our schools to be very reactive and placing those people not in prevention roles, but more in intervention and treatment roles. Our schools, and I'm really proud of them and how they did this year. It was a really difficult year. We lost a lot of teachers this year. They cannot put out a wait list. They have to be ready to meet kids' needs every single day. And so, really what that made is that our schools became the behavioral health system right after the pandemic. And so, as you can see, we weren't quite ready for all that. We didn't have the proper amount of ratios. The other thing we really realized is just putting people into our schools without a system. We got less, it was great. Principals gave us the thumbs up. They were so thankful that we were able to find funds to get social workers, more school counselors, school psychs. The problem was that if they went into schools without a system, again, they were really funneled into that tier 3 instead of a systematic system. So next slide. Part of our goal and that we're hoping to achieve in the next couple of years is a comprehensive prevention services. And really what schools need is, we can't say that one program is going to meet every school's needs, because each school, like communities, are different. So what we do want to empower with them is, as issues arise in the communities and move into our schools, they have the tools needed to implement the interventions to meet the needs of staff and students. One of that's, if you kind of think of it as an operating system, kind of like your computer. So either whether you're a Microsoft or an Apple person, you have that operating system that you can then plug in apps or programs to meet your needs. Very similar to schools. So schools are really good at this on the academic side. We have ways we meet kids, we have screenings, we have ways to make sure that kids have interventions if they start to struggle academically. The problem is this year, after the pandemic, kids really started to struggle social emotionally. They had trauma. And so many of our schools did not have what they needed to diversify those interventions and meet the school's needs. So that's what MTSS, PBIS, Interconnected Framework is all about, really giving the school that system, that platform to operate in that we focus on prevention, that high quality instruction. We have teams. We don't want teachers to feel all alone dealing with some of the students' issues and getting burned out, right? So we want to ensure that schools have teams ready, they're meeting, and they're looking at their data. And that's the problem-solving models and database decisions. And then the systematic implementation of interventions. So you heard about a program today around prevention for opioids. If that was needed at a school, if they were operating MTSS, they would take a look at their data, look at evidence-based practices, and then be able to kind of plug that in quicker. The other really important thing about MTSS is that it has an element of progress monitoring. So this progress monitoring is really important when it comes to equity. We don't want to just stick kids in interventions and hope that they work. We want to make sure that kids move into interventions based upon data, and that the intervention is actually working, and that they are, staying in school, being able to focus, maybe helping with the trauma that they're dealing with, whatever the issue may be. We want to make sure that there are ways to ensure that the intervention is properly implemented, and then also that it's getting the outcomes we hope. If it's not getting the outcomes we hope, we can then move back into the teaming and again, try some other kinds of interventions, whether it's tier 2 or tier 3. You hear a lot about the tiered continuum of supports, and that really is what empowers a school to meet individual students' needs, not through discipline, right? Not through suspension and expulsion, but through meeting that child's needs wherever they may be. Sometimes children, when they have unmet mental health needs, some of them, not all of them, some of them act out. And so making sure that we have those tiered continuum of supports instead of isolating or sending them home. Regular screening, not all of our kids act out. Some of them are internalizers. We worry about our internalizers probably most. They do really well hiding their struggles. And so that there's screenings out there, just like we screen for math, there's screenings out there to screen for behavior as well, so that we can capture those internalizers just in case. And again, a way to implement evidence-based interventions and improvements. So what does this mean? So we've tried this out in some of our schools. Next slide, please. Oh, I just wanted to let you guys take a look at the student population in Nevada. So we have almost 500,000 students here in Nevada. 80% of them are located in Las Vegas. And Nevada is extremely blessed to have a very diverse student population. In fact, our probably student population is diversifying faster than our adult population. So it's really kind of exciting. But I just wanted to give you a quick snapshot of the students that we have been talking about. Next slide. So the implementation has rolled out, and when I say we, it's not the Department of Education rolling this out, it's a partnership. It's a partnership between the University of Nevada, Reno, it's a partnership with our districts, and a partnership with the Nevada Department of Education. You can't do any kind of complex works independently. And so what we've learned is that you really need multiple agencies coming together to do these complex works and really increase the prevention services and interventions into the schools. So 10 districts, 149 schools, 99,000 students, and 41 trainings occurred in the last year around MTSS. And again, one of the outcomes, so we have hard data, and then we also have anecdotal. One of the pieces, anecdotal data we have is interviews and expressions from our teachers, again, saying they're feeling very overwhelmed. When there's systems in place and teachers know how to access those systems and how, to be part of that team, to put in the interventions, teachers start to feel a better sense of coordination and a little less overwhelmed by all the different stuff piling on. What we learned is that teachers and schools are places where people want to implement things, right? That's where the kids are. They're there every day. And so what happens is we get restorative practices, and we get SEL, and we get A, B, and C prevention programs, and we get this, and it starts to pile on. And if it's not coordinated, it starts to feel very overwhelming and disjuncted. So again, what we're bringing to you today is that operating system to align that and to get everyone working together around, is this working? Is it meeting the needs of the school? Are we meeting the diverse? As you can see, our student population is diverse. So are we meeting the diverse populations that we are blessed to serve? Next slide. So if you are around MTSS or PBIS, or if you've gone into public health, MTSS and public health systems, very similar. This is nothing new. This is decades of research that this works. What we really want to do is put most of our emphasis and funds into Tier 1. And in fact, University of Nevada, Reno is very firm about their training. They really want people to get and understand Tier 1, which is that prevention, wide system practices before they move on to Tier 2 and Tier 3. Not to say that our schools aren't doing Tier 2 and Tier 3, because they have to, right? Kids show up to schools, they've had a traumatic episode occur, there was a tip and safe voice or handle with care, and schools have to respond, right? So how do we appropriately respond? If schools are not doing a Tier 1, they again they will only get into that response mode, and the amount of kids needing services in that Tier 3 framework starts to rise. And that is a very unsustainable trajectory. So for example, in Tier 1, we have social emotional learning. So how do we embed social emotional learning into the curriculum itself? How can we do this? And our schools are really good at prevention, right? Teachers have been trained to do this. How do we embed the social emotional learning right into math, social studies, all those kinds of things. So we're working at NDE to really look at aligning social emotional practices with our Nevada standards to help out our teachers. Restorative practices. So this is a body of work that says, let's not punish behavior. We're schools, let's teach behavior. So that's the premise, is making sure that we teach behavior and that students are able to handle conflict, repair after a conflict if necessary, and to make sure that they're learning from it and not just getting lunch detention or getting suspended or worst case scenario, expelled. What we've really learned, right, is that we can suspend and expel, but that child is still in our community and it's an unsafe practice, right? We hear about what isolation does. And so really making sure that that student remains in the system and their needs are met. Now, I'm not saying that we focus on student safety over teacher safety. There has to be a balance, right? If it's an unsafe situation, we move right into discipline, right? But that there are ways that the child can restore and get back into school. It may look a little bit different. And then substance abuse prevention, again, really important in that tier 1. And then making sure that our schools know about trauma-informed practices. Now, all these things could look really and feel really disjunctive and overwhelmed if we didn't have an operating system in place, and that's that MTSS. Next slide. And tier 2 and tier 3, again, is really looking at, this is some of the work that Dana team has been really working on with the schools coming out of the pandemic. We have children presenting with pretty substantial needs, right? Our schools, they have to be able to respond.
You're gonna have to do it. It's not let.
So that is really the tier 2, looking at it a little bit ratcheting up. So are there some group work, other referrals, those kinds of things? And then of course, tier 3 is to support the student, whatever that intensive service might need to be. So did you want to add anything around tier 2 and 3, Dana?
No, I don't think so, but this is where the sustainability will come in. We'll talk about that too. These are where you could bill. So a school district could bill for these interventions and practices, and then have a return on investment where they could better align their budget. Rather than using education dollars for healthcare services, they could use return on investment of healthcare money for healthcare services. And so that's part of the system we talked about in the beginning.
Yep. Next slide. So I want to talk about a little bit about some of the outcomes that we have had implementing MTSS right here in Nevada. UNR has funded an outside evaluator to come in and work with the districts and them to really take a look, are we actually making positive outcomes for students? So this is just a little flavor. So MTSS, really looking at fidelity. When it is implemented with fidelity, it declines the student problem behavior. So not only is this great, right? Less possession of weapons, less distribution of controlled substances. What this also translates is more time for administrators. Because if administrators are not taking, if there's less incidences to deal with, they actually get more time back into their day to actually do education, which is probably what they were hired for in the first place. So one of the key outcomes that was kind of a surprise for us in MTSS in the implementation is that it actually returned time back to our administrators. 31 decrease in dropout rates, and then gains in school climate. We measure the school climate. When we measure school climate, we also disaggregate it by the diverse student populations. I kind of showed you in the beginning slide, because all means all, right? We want a climate that's not just good for Hispanic or Caucasian students. We want a climate that's good for all of our diverse kids. So we really take a look at making sure that we use data to diversify and making sure that all of our kids feel safe in schools. One of the population that we need to work on across the state that does not typically feels less safe than any other population in our schools right now are the children that identify as gender fluid. And so that's one of the, it's one of the things that we can work together on as a state. And also one of the great things about really focusing on social emotional and behavior and making sure that it's aligned and supported and prevention is that we actually get an increase in academic performance, which is exactly what we want in schools anyway. So we kind of feel like you get more for your money when you really look at a systems approach. Next slide. So here's some of the individual data. All of you will get this presentation, so you can kind of take a look at it on your own. And if you have any questions, you can give it to us. But what you're going to see is that here, that green line is schools that are implementing with fidelity. And what we found is that our data got all skewed with the pandemic, right? So we saw raises and we saw steep inclines and declines because of the pandemic. But what we learned is that the schools that were implementing MTSS with fidelity did better with the schools that were implementing MTSS without fidelity. But even those schools implementing without fidelity did better with schools that were not implementing any systems approach. So you could see that we had reductions in distribution of controlled substances, possession of controlled substances, and alcohol. Next slide. And then again, the discipline. So I don't know, a lot of the discipline, especially in Clark County, was widely publicized in the media this year. And again, what we saw is schools that had an MTSS in place, they still struggled like the rest of the schools, yet they did a little bit better. Next slide. So a couple of gaps. Here's the gaps we have. Currently, only 149 schools out of 752 are implementing MTSS. And you might say, well, Christy, for the amount of years you've been working on this, why only 149 schools? Is because work with outcomes like this does not come easy. It's not a magic wand that you go in. It takes a good 1 to 3 years for full implementation. You really have to get the schools to be comfortable with looking at their data and making those choices and the teaming and to kind of really kind of get these systems in place. So then once they get their systems in place, then they can onboard, right, whatever interventions that their students or their staff really needs. Also a gap is not only do we have a gap in the systems piece, we actually have a gap in the people that can actually implement the intervention. So those are the two main gaps that we are bringing for you today. Next slide. So our recommendations is we're hoping that this team would want to recommend that you join with Department of Education and UNR to expand the capacity to provide MTSS training and coaching to all Nevada local education agencies. So we do have proposed budgets for that. Again, we have the data. We also have the anecdotal data around, this is a way to help us keep our teachers to manage some of the complex situations that are in our schools, and then also be able to plug in the interventions that staff and students need as the pandemic hits, as we're hoping that the opioid wave kind of goes away with fentanyl, but if there's something else, then the schools are ready to meet that because they have their operating in place. So that's the system, right? And that system emphasizes prevention. And it also makes sure that we're doing a good job of keeping the offerings of tier 3 services down around 10% instead of the 30% we're seeing now in some of our larger districts. And then the priority 2 is a short-term ask of increasing school-based qualified mental health professionals. And the reason why I say this is a shorter term ask is because what we hope is by placing these individuals in our districts, it will give our districts some time to one, implement MTSS, and then to two, be able to reduce the numbers of kids that need these services, but they're not going to go away, right? So we need a way to sustain this indefinitely, but it will give districts time to also be able to bill Medicaid. Billing Medicaid outside of the IEP in Nevada is called free care. And there's a couple of hurdles that we need to get over before schools can actually do that. So we have a priority one, enhancing the prevention infrastructure across all of our schools in Nevada, and then also giving a shot in the arm to our school-based health qualified mental health professional workforce. These are the people that could be able to bill Medicaid and then also be able to supervise people that may not have the licensure. Did you want to say anything about?
Yeah, I want to add in one thing, just because I think it's important to know, and so that you all know, we talk about billing Medicaid, but it would be done on a back end. So no youth, and preferably no school-based provider would really know. It would take it from a electronic health record and bill when possible. The services will be provided to the youth and family no matter what. So that's where the system comes in, is that they choose to get services through the school, they get that. But if we can, on the back end, we'll bill Medicaid so that we can have a return on investment and an income coming into the district. But I really want to make very clear, it's not that we're only going to work with Medicaid recipients, and that this system is designed for all students. And so if we can bill, it's a cherry on top, because we can start to have an income go into the schools for healthcare services. But those providers don't need to know, that's a back sort of behind the scenes thing.
The other piece that we are hoping of increasing the funding and diversifying the funding buckets for our schools is that right now, schools are doing tier 2 and tier 3 services for students. In fact, most of your Nevada students are getting their behavioral health services in your schools. It's just a fact. We didn't design it like that, but kids show up to school and they have had traumatic episodes. Maybe an adult was just jailed. There was a handle with care, a safe voice tip, those kinds of things. So schools have to deal with it. They're already dealing with it. Right now, we are using education dollars for those interventions of tier 2 and tier 3. So imagine if we can appropriately and correctly instead move in Medicaid dollars, like many states have, to offset those tier 3 and tier 2 services. What that does is frees up those education dollars that are not and allows schools to focus on prevention. And that's where our schools excel, right? That's where teachers really can make the difference, is in that prevention framework. So that's one of the reasons we're looking at like a two-pronged approach. Getting the amount of ratios up, and then being able to bill, meeting the needs of our kiddos in tier 2 and tier 3, simultaneously doing these systems so that we're moving away just a reactive approach and really going into a prevention approach. Next slide.
I think we are done.
And we are done. So if you have any questions, again, we do have our partner here from the University of Nevada, Reno, Dr. Greenwald. She and her team are the ones that have implemented MTSS across the state. So if you have any deep questions for her, feel free to, she's here.
Thank you so much for that presentation item. So I want to ask just a quick clarification question, because it might be able to filter some of the questions we get from committee members. So Christy, just to be sure, the folks that you have helped present can answer questions on the MTSS program that you just presented and the initiatives that we're doing for behavioral health in schools. Can you also answer questions regarding NDE's curriculum on health education? Is that something that committee members can ask, or
you totally can ask, and if I don't have the answer, I will get the answer for you guys.
Okay.
So, yeah, we're here at your service.
Okay, I just wanted to make sure in case of any committee members have. I see Senator Ganser, if you want to go first, and then we'll go to Debbie Nadler after. So Senator Ganser.
Thank you, Senator Donate. So thank you, Christine, Dana, for the presentation today. And you said you've got a budget for this. So I guess I've got a couple of questions, what the budget would be to implement this, but also on the social worker piece, what does our pipeline look like? Like if we need 1,000 more social workers in Clark County and several hundred in Washoe County and maybe in the rurals too, how are we working on our pipeline? And have you figured out how we can improve that? Because I don't know that we have that many. So what are your suggestions?
Absolutely. Christy McGill for the record. Good question. So the first question is, yes, we do have a budget to expand MTSS across all schools, and I could submit that upon request if you guys would like. And then secondly, about the pipeline. So yes, very difficult. And so what we have to do is we have to do two things. It's kind of like, I'm from rural Nevada, so I learned from our farmers that they have to build the market while they are harvesting. So it is the same approach. So we need to make sure that our schools have funds. What is happening now is our office has been blessed. We've been able to get discretionary funds for behavioral health and to improve the ratios. But those funds come and go. They're like this, right? And so the schools start to get a little shy about hiring people and then having to lay them off and then hire. So what we're really looking is for some sustainable funds. As you probably know, there's no requirements for ratios of these kinds of people, no school counselors, no school psychs. And so if the budget gets tight, unfortunately, we have required ratios for teachers. Those are some of our first professionals to get cut. And so we're kind of in this cycle. So we have to level out that cycle. We have to make sure that the funding for these professionals is more secure so that people feel confident moving in here. And then we are working with UNR, UNLV, Nevada State College, and Great Basin to look at that workforce pipeline. We really want to start with our students. If we can get our students interested in these professions, our students are already diverse, and it will naturally and organically diversify Nevada's pipeline, which we also need, right? And so we have a grant right now that looks at dual credit for some of this so that we create nice ladders, career ladders from high school into programs at UNR. UNLV, Nevada State College, and Great Basin. So we have a grant to really look to make sure that we have those things. And then also to make sure that we have funds so that students can do the internships required without, so that doesn't become a barrier, which has been identified in the past, that those unpaid internships have been barriers in the past. So really working with our institutions to take away that barrier, make sure there is funds or that there's ways that schools can hire interns and, so they get the training they need without having to taking out loans or, having a second or third job.
Thank you. I appreciate that answer. And I think I'll follow up offline and get a little more detail from you, but I think it's important to submit your budget to the committee so that we have an idea of what it would cost and how we can sustain it too. So thank you. I really appreciate your work because I do think schools are the touch point where we can help so many young people. And I think that's where it sort of starts a lot of times. So I appreciate your work on many fronts, and you know that. So thanks again.
Thank you.
Thank you so much, Senator Gainser. And I would agree with you. I think we've had discussions as to how we can increase the pipeline of social workers in this state. It's a very tedious process, as you might all know. Licensure always comes up. Affordability of tuition to help the graduates go through school, all that all plays into it. But let's go to Ms. Nadler if you have any questions on this presentation.
Yes, thank you so much, Dana and Christy. Dana, we had spoken years ago before COVID. I don't know if you remember speaking with me. It's Debbie Nadler. Very important for what y'all are doing. I do have a couple questions. This is my passion too, primary prevention and education and mental health. I know Governor Sisolak mandated mental health ed in all the schools, and he did this before COVID. So my first question would be, did y'all receive some kind of funding for this? And are you using that funding for the mental health providers for our school systems? And I have another follow-up question on that though.
Yes, we did. We've had several right now, especially under Governor Sisolak. We've used the federal recovery dollars. So both NDE set aside dollars just for mental health providers in our schools, and then also the districts themselves use those dollars for that. I'm going to be completely honest, they are all very worried about this fiscal cliff and why we're working really hard in the next 2 years to get this system in place and then to bill and then for our schools to be able to bill Medicaid. We have some mentor states. We've been looking at Michigan that's been able to increase their ratios and services only almost by 800% by using these strategies of billing Medicaid. So we've got the answers are out there, but there's still a lot of work to be done. Our system is a little on the informal side when it comes to school-based services. And so, getting the MTSS, getting it formalized, getting platforms. I mean, it's like an onion, right? You start to unfold like, okay, how do we really do this? And it's like, oh my gosh. So one of the onion layers we just discovered, and Dana's done such a good job of leading problem solving around it, is that our districts didn't have ways to actually document behavioral and social emotional interventions. And so, just taking that head on and looking at ways of how do we document this, making sure that we have good parental consent policies, care plans, how kids get in and out of interventions, and so that these interventions become equitable. What we didn't want to see is kids hanging out in a anger management class because they're making their teacher mad for 3 years. Like, we actually have data that says, here's some of it. He's actually, or she's actually struggling with trauma. We're going to use coping skills, those kinds of things, set up a care plan around that coping skills and actually be able to support that child really well in their school environment. So yes, it's kind of a long haul. And I don't know if did I answer your question good, Debbie? Is there?
I mean, believe me, I appreciate all you're doing. I just wondered how much of it was, being already funded by the governor and what the governor has passed. I understand what you're doing. I think it's great. I think more needs to be involved, in my opinion. I recognize everything y'all are doing, and I think it's absolutely wonderful. It's very important, but there's something missing here. And what's missing here is we had 114 police officers respond to different schools throughout just Clark County alone for drug problems a few months ago. The kids don't know, the parents don't know, the teachers don't know. I've tried to get in personally to every school. So I think these programs are great, but I think what's missing is peer involvement, people who are in recovery talking to the peers. I've been to school programs. All they're focused on is cigarettes and vaping. It's so beyond that. I lost my cousin in October, 13 years old. She took a pill at a party. And it was what she thought was Percocet. It was fentanyl. Mm-hmm. The kids have no clue. I'm telling you, I'm in every parent group across this county. I have to tell the parents about fentanyl. They don't know what it is. The kids don't know what it is. So in addition to what you're doing, we need to really focus on organizations that are already doing the work to get into the schools for free. I went into a middle school. The teacher called me and wanted help. She said she went to the bathroom and half her kids were doing heroin. This is middle school. This is 12 and 13-year-olds. I guess I'm, your chart that you showed goes through 2019. Our overdoses have tripled since then. I agree with the mental health and the social emotional learning. I think it's so very important because we all know that when kids suffer some kind of trauma, they do one of three things: hurt others, self-medicate, or commit suicide. So that would be a great primary prevention. But the other primary prevention is stopping them before they start, before they take that first step on the ladder. So as far as primary education, why are these kids wanting to take a pill for the first time? The ones that we are losing to fentanyl, that think they're getting an Adderall, a Percocet, because they don't know. They don't know. There's not enough people in the schools. They're not going to listen to the teachers. It's hard enough to get them to listen to their parents. If there was peer support in the schools, it would be very, very important. And this is why I brought Joe Engel on in the first place, because of his group. It's Alternative Peer Group. We were joining forces to do a school-based program to get them thinking. The art of communication. Just say no. A poster contest. Sing a song.
Ms. Nadler, we can discuss that when we get to the recommendations, but I just want to stay on
Sorry,
track.
I'm very passionate. I'm sorry. I'm very passionate about this.
Let me help you out. Okay. So I have a few questions for NDE. You can say yes, no. I just want to have an understanding as to what we're doing versus other states. Okay. So first things first, I've been pulling a lot of resources, looking at what the CDC recommends, looking at what other states have implemented. You mentioned Michigan. Michigan has a really great comprehensive health education model. I also want to mention I graduated from high school less than 10 years ago, went through the DARE program, had abstinence-based education, just making that full disclosure for everyone on this call. Okay. In NRS, is there a requirement? So I'm going to go through rapid fire. In NRS, is there a requirement right now that the curriculum is delivered by trained instructors?
And you're on.
Whoops. I'm live. So for any curriculum or curriculum related to health and prevention?
Health and prevention.
I will double check that. So I think there has to be a licensed teacher in the room, but let's say a professional from the community wants to come in and, that really knows this, that person can come into the classroom to do that. But that requirement that there's a licensed person in the room remains, but I can double check that with you.
Okay, great. Is there a requirement that the curriculum in Nevada when I say curriculum, I'm specifically talking to, I actually already have the health education curriculum based on each divided grade level, and of course, by different subsets. So when it comes to substance abuse or substance misuse, is there a requirement in Nevada for NRS that the curriculum follows federal or national standards, guidelines, and or recommendations? Does that exist right now?
Okay, say it again. Let me write it down.
In Nevada, in NRS, is there a requirement that their curriculum follows federal or national standards, guidelines, and or recommendations?
In our standards, is that correct?
Correct.
I don't think so, but again, I'm not the, we have a division that really looks at the curriculum and standards led by Dave Brankamp. So I will double check that. But as of right now, I think they really just allocate what needs to be taught, and that it may be aligned to federal. But is there a line that says it must be aligned to federal? I'm not recalling anything right now, but again, I will double check that and get back to you in writing.
Okay, sounds good. Next one. Is there a requirement in NRS that the curriculum is appropriate for age or developmental stages of the students?
Yes, I think that part is in NRS. And again, I'll have to look to be able, I'll pull that NRS piece out and give it to you.
Okay, good. I'm okay. Is there a requirement in NRS that the curriculum is medically accurate?
Again, I have to look in the health standards to take a look, but let me do that for you. Medically accurate. I'll get all of this, and if it is in NRS, I'll give you the NRS line. If it's not, then it will be a gap.
Yep. And the last one is, just wanted to make sure if the instruction is sequential across grade levels. I think the same clarification. So
yep.
From my understanding, the answers for most of these are no.
Yeah.
So that means, and that information has been provided to me from the CDC outline recommendations. If that is correct, of course, that means that we have major gaps in our health education system to promote health literacy, and that we're not delivering it based on what NRS statutes say. It will take a lot of brain work, a lot of work to reform that system to make sure that the teachers that provide health education are trained, are routinely trained, that we have access to providers to come into classrooms, to reform the entire system, to follow possibly like Michigan's comprehensive health education model. So that's what I wanted to get out of this. That's what I wanted to get out of this presentation. So thank you so much. I would love for follow-up, and if you can deliver it to that committee members, it would be helpful for us to understand what the gaps are, so that when we're discussing and deliberating policies, we understand where that is. So that's kind of what Ms. Nadler, our committee member, was trying to get at, which is we fall severely behind other states when it comes to comprehensive health education reform. Okay, now that we moved from that.
Chair, I noticed that Dr. Greenwald had her hand raised. I'm not sure if she was responding to a previous question from Ms. Nadler.
Ms. Greenwald, did you want to respond before we move on to our committee member for a question?
If it's appropriate for me to do so, I would love to.
Sure, please proceed.
Thank you. This is Dr. Ashley Greenwald for the record. I just wanted to share also, one of the things I think that may have been overlooked a little bit in the presentation is the focus on evidence-based practice. So that's really the heart of MTSS, is that we are collecting data, outcomes, progress monitoring on evidence-based practice. And Chairman, you asked, does the curriculum follow federal standards, guidelines, recommendations? One of the things that we feel extremely strongly about, and that we train and educate all of our school sites on, is the use of evidence-based practices, how to identify, recognize, make sure that we're using evidence-based practices. So you brought up DARE as an example of a drug prevention education program that you experienced as a student. And that, in fact, is not an evidence-based practice on the drug prevention registry. So that is exactly what we're talking about here, is that a big part of the work of MTSS is actually going in and we take a look, we go through it with every school, we do what we call an initiatives audit or a practices audit. So we take a look at every single practice, program, intervention that a school is using. We go through and we identify, is it evidence-based? Is it working for your school sites? We go through to see, how is it being trained? Who's coaching the teachers? How do you get more support? How do you know if a student is successful in that program? So that is one of the components of the work of building out that infrastructure and system, is to really hone in on, do we have adequate supports in place to meet student needs? And oftentimes what we find in a lot of our schools, and especially in our rural school districts, is that we have these programs that have been implemented for 30 years, 40 years. No one knows why we're doing it. They're not necessarily effective, but we're still doing it. And so we help the schools clean that up, right? We teach them to recognize, we teach the administration to recognize what is an evidence-based practice, how do I identify it, and how do I match it to the student needs at my unique school? And so we're using, for example, SAMHSA's NREP registry. Some of the drug prevention programs that we have currently in place that we're supporting, and we've purchased curriculum, we're giving it to the schools, we're helping to train and coach and embed those curriculum. Too Good for Drugs, BOTBIN life skills, acceptance commitment therapy for substance abuse, all evidence-based programs on the NREP registry. So I just wanted to, for the record, make sure that you understood that we are very focused on embedding evidence-based practices, evaluating the effectiveness, and that's why we're starting to see the shift to have better outcomes for the students at the schools that are implementing MTSS. So I wanted to just share that piece too. Thank you for the opportunity.
That's amazing. Thank you so much for detailing that. I think that's important, as you mentioned, as we're going through this, that we're supporting policies that are evidence-based. So thank you so much. Let's go to Ms. Johnson. Please proceed with your questions.
Hi, thank you, Chair Dignate, and thank you to the presentation team for today. I had a couple of quick questions, a list that actually some others have already answered or asked. So thank you all for preceding my list. This question is probably for Chrissy and Dana. Is the MTSS system designed to be K-12? And can you talk a little bit about, if so, like what that might look like across the developmental spectrum?
We are actually going to punt that to our MTSS expert, Dr. Greenwald.
Absolutely. This is Dr. Greenwald for the record. Thank you for that question. Yes, absolutely. It is K-12. Actually, there is some implementation also in pre-K. So it is pre-K-12. And one of the things that Christy had mentioned earlier in her presentation is that the school sites select their interventions. So MTSS is a framework. It is a framework, an operating system essentially for data, systems, and practices. Those practices, like I was sharing just a moment ago about the practice audit that we conduct, those practices are selected for the individual students at the school sites. We also work, for example, in alternative education sites. So the practices that are selected at an alt ed high school are very different from the practices that are selected at a elementary school. What supports are in place for the students differ school to school. And that's something that's really important for contextual and cultural fit.
Great, thank you. Would it be okay, Senator, to ask a few questions? All right, thank you. I was looking through, I know we just briefly touched on the school climate transformation report from 2020 and saw that you highlighted some of the student outcomes. And I was wondering if there were any specific teacher outcomes that were positive as a result of the implementation.
Dr. Greenwald, again, for the record, thank you for that. We do track some teacher outcomes. I don't have them in front of me at the moment. I'm happy to share the full report with you. We do mostly anecdotal teacher comment, though. So there are some surveys that go out to educators, to participants in the leadership roles at the schools, participants in the leadership roles, the administration of the school district. So we do have a lot of data, but again, it's more anecdotal survey data as opposed to specific data, that we don't have any teacher retention data based off of MTSS, but we do have, did you benefit from this training? Are you changing your practices or the way that you help support students based on this? And actually, I do have one statistic in front of me, just because I happen to have it on a slide here. 94% of teachers and educators that were surveyed from our external evaluator reported that they did change the way that they supported students based off of the trainings that they receive and the coaching they receive through MTSS.
Great, thank you so much for your answer. Education is near and dear to my heart and my family, so wanting to just make sure that the system is, really beneficial for all involved as we think through the implementation.
Absolutely, we feel the same.
Great. And then just one final question, if that's all right. If there's time, I might have a few more. So given the diversity of our district and such a strength, how do tier 2 and tier 3 services account for cultural sensitivity or cultural humility as they look towards implementation?
Dr. Greenwald, again, for the record, thank you for that question. So one of the things that we do focus on specifically is cultural relevancy. That is something that is absolutely embedded in all of our trainings. We make sure that we identify the specific populations of students at the schools, the specific populations of teachers at that schools, and we encourage the selection of evidence-based practice based upon what the evidence shows supports different cultural populations. One thing too that we get asked often is, there are certain practices that, for example, we support a lot of Native American school sites. And so one of the things that we get asked, there are certain practices that the elders have had in place in the schools for a long time. And so they say, well, this is not this is never going to be in an evidence-based practice registry, but this is something that's really important for our culture, for our school. And we say, absolutely, you know, we absolutely recognize that, we appreciate that, we include it. And what we do is we actually help them to understand how to determine if it's meeting student needs, how to essentially progress monitor to make sure that the students are having the outcomes that are intended based on some of those cultural practices. And so they also learn how to start to look at some of the practices that are more, you know, sort of cultural and homegrown, and to identify, is this meeting the needs? So for example, you know, if we've got major drug abuse problems in a school, are we meeting the needs through some of these cultural practices? And there's, you know, we would certainly never take away some of those really important cultural practices, but we might add in an additional practice if it's not meeting the student needs. And so that's something that we look at. We are, you know, we really try to make sure that we're being culturally relevant. The other thing that we do is to include family and community participants in our teams. So MTSS is very team driven, teaming both at the level of the district and also at the level of the school site. So the school sites, we encourage, and actually one of the components of our fidelity assessment is, do we have community and family members represented on the team to make sure that we are culturally relevant and responsive?
Thank you.
Thank you so much. I think Ms. Nato, do you have one more? Do you have any additional questions specific to this presentation? I think she put her hand down. Don't see any more.
I'm sorry, yes, I do. Just one quick question. When you do the MTTS programs in the schools, is it mandatory for all the teachers to take the courses, or is it selective? How do you base which schools to go to, and how are y'all updating your programs based on the ever-changing epidemic, especially with the fentanyl right now?
Yeah, thank you for the question. So again, MTSS is a framework, and I want to be really clear about that. MTSS is not a program. It is not a practice. So the framework is essentially what Christy was talking about, is the infrastructure piece. The way that we roll this out is that we, being at the state, we support and represent the NDE, partner with the NDE. On behalf of the NDE, we go out and train and support the local educational agencies or the school districts. They have a team at their district. Their district currently, in this current model where we have sort of select resources available for this work, the district identifies school sites for participation based off of need. So the schools that have the greatest needs are included in the cohorts for training and for coaching. We also, at the local educational agencies, build in capacity. So we want to strengthen the capacity of the district. The district has coaches for MTSS that they identify, that we spend weekly and monthly and quarterly providing direct feedback to, trainings, specific components, so that we can build the capacity at the district level. We also train the school sites. So the schools identify their teams, and they also have what's called an internal coach. So at the district, we call external coaches. In the inside of the school buildings, we call them internal coaches. Those internal coaches that are selected also come to our trainings with a team. This is an administrative team, including the principal. Oftentimes there might be a dean, a vice principal on the team, someone representing general education, someone representing special education, and also a behavioral health professional. So that team comes together with their internal coach. They receive the training directly from us. And then we give them, we call them workshops. They're not really trainings, we call them workshops. They develop materials for their school systems in our workshops. Then they go back to the school, and it's their responsibility to disseminate that information to their educators. It's part of our fidelity assessment. So we go through and we walk the school sites 3 times a year to make sure that all of the components are being implemented as we have designed them. And we can actually monitor school by school, we aggregate by district, we aggregate by the entire state, what our fidelity of implementation looks like at each school site, at each district, and at this level of the state. And so we can very clearly monitor how many people are receiving certain, what information. The other thing too that I wanted to share is that you asked, how do we make sure that all of the teachers are trained in the program? Those programs, those evidence-based programs, are selected specifically by the school teams or by the district teams. So some districts have district-wide evidence-based programming that they implement. Some districts leave it up to the school sites to select and give them more autonomy in the selection of their practices at the level of the schools. And so those practices are something that we monitor through data. The rollout actually happens at the level of the school. Does that help to answer your question, Ms. Nadler?
It does. Thank you.
Absolutely.
Thank you so much, Ms. Nadler. I thought Jessica had another question. Yep, go for it.
I live for questions, but in the interest of time, I'm happy to take them offline to get to the rest of the agenda. Thank you.
Great, thank you so much. Any other questions from any of the committee members before we proceed? I don't see any, so thank you so much to Dana, Christy, and all our presenters for this robust conversation. I think it's very important that we continue to provide services to our students, and I'm looking forward to having further conversations. I know when we, in the interim HHS meeting from the legislature, we always talk about what are the certain triggers or mechanisms that we can force collaboration, not just with NDE, but with DHHS and other subs to really deliver the services that students need. And so I think you guys are delivering that. So thank you so much. And of course, if you can provide to us the budget that you would need to expand this to other schools and the requirements outlined, that would be really great for us to look at and review. So thank you. Really appreciate it. Let's move on to our next agenda item, which is to review the process for prioritizing recommendations in upcoming meetings. I do have a few updates for the committee members on a few questions that we received. So let me start off first by mentioning an update on harm reduction recommendations. So I'm going to give a few updates as to what conversations have happened based on recommendations from some of the subcommittee members, and then we can move on and talk about the actual recommendations that we received. So first things first, harm reduction. Harm reduction was brought up by one of the subcommittee members as a potential discussion point, simply because there was a concern that harm reduction was either being, there was a concern that harm reduction recommendations could crowd other recommendations related in prevention for the prevention subcommittee recommendations. Other subcommittees have also requested speakers related to harm reduction and have harm reduction specialists as subcommittee members. Because of this request, so there was a request to remove harm reduction out of the prevention committee and move it to another one, or to figure out what the strategy would be for it. So the three subcommittee chairs met and determined that harm reduction will stay in this prevention subcommittee, but recommendations related to harm reduction will be included in the for future review section when submitted to the full SURG committee and in the final report. And in 2023, a subcommittee specific to harm reduction could be created and recommendations could be included in the next report. And if there is any consensus among the entire SURG committee about harm reduction strategies, such as naloxone distribution, then it could be included as part of the recommendation in this year's report. So I wanted to make sure that I had that clarification before we talk about recommendations entirely. But also I want to take this moment to share and perhaps collect feedback from all the subcommittee members as to how we will begin to reduce or determine what our final recommendations will be from this subcommittee. So SEI staff will, so there are two ways that we can choose to narrow down the policies that our subcommittee is getting. SEI staff would send the updated recommendations, including both the IHC recommendations and member recommendations, to the tracker that we have received from our subcommittee members, with an additional column for ranking and instructions based on whether or not members want to weight the rankings so that the weights diminish in descending order from 1 to 5, or so that our recommendations are equally weighted. So essentially, there are two ways that we can that I would like the committee members to deliberate right now as to how we want to narrow down these approaches. One, we can rank all of the policies from 1 to 5, as I just described, and we can keep it together in a tracker, or we can ask each of the subcommittee members to pick their top 5 with all the choices equally weighted. That way we can see if some of the proposals align with each other. We might have the same top 5 priorities, or there might be some overlap, or we can choose to go policy by policy by policy and rank it individually so that we can get an aggregate result of an average. So is there any discussion or ways that you would choose to narrow down these policy recommendations? Jessica, I see you first, and then we'll go to Senator Ganser.
Oh, I just had a quick question, not
Oh.
discussion. Are the other subcommittees, have they selected a particular path? Are they doing the ranking order or the ranking individually?
I'll let Emma answer that if you can deliver.
Sure. So I believe the 2 other subcommittees have done it slightly differently. So one did it through that weighting process, or weighted. So they prioritized within their top 5, which one was 1, 2, 3, 4, 5. And another subcommittee, they just picked their top 5. So all of those top 5 from each subcommittee members were weighted equally.
And one quick follow-up question. Was their criteria outlined, or just like, these are the top 5 for me? Like was it based on impact on the population, or funding availability, or anything like that, or just straight out across top 5?
I believe it was just their top 5. I would ask Laura Hale, who's also on our team and has been working more closely with the other subcommittees, to weigh in on that.
Thanks, Emma. The first committee just ranked theirs and weighted them without any specific guidelines. The second committee, the response subcommittee, is in the process of ranking. I don't believe that Assemblywoman Tolles is wanting them to weight them in that case, but I don't think they've decided. I think they still need to discuss that process. They had to reschedule this month's meeting, so they didn't get to that. And they may end up having some other criteria in there. The first committee, the treatment and recovery, did not have any specific criteria. It was just, here are all the recommendations. Tell each individual person, identify independently your top 5 through a staff person. And that has to do with the open meeting law and not having discussions offline outside of the public meeting. So they did that independently. Staff then gave them the weights accordingly to say, number 1 is the highest, number 5 is the least. Does that help?
It does. Thank you so much. Thank you, Senator Danyate.
Senator Ganser.
Thank you. That helps resolve some of my question. I was trying to figure out why we're weighting them, because in my mind, if you rank something as 1, that's your priority, and then, down the list or down the line. So I want to make sure if we pick, several or choose several recommendations, that it's understood that 1 is the strongest recommendation that we have, and so forth. So if that's weighting, then that's fine. If we're signaling by just making it number 1, that's all right. But if another committee's used weighting, then maybe we need to consider that. And I'm not sure how they did it, or how you figure out what the continuum is. But I have a feeling that we'll probably have stronger recommendations, or recommendations that we think are more important than others. Although there will be, all of them will be important. Some of them are like the have to do's versus would like to do. Thank you.
So Senator Ganser, so it sounds like you would prefer the weighted option, correct? Of what?
Well, if that's the way we can emphasize that we think one methodology or one system is better, the best or better than others, then yes.
Sounds good. Okay. Any other comments from any other committee members on this feedback? Debbie?
Whoops, I'm so sorry. I agree with what the senator just spoke, the weighted. I think that's great.
Sounds good. So it sounds like most of us are in agreement that will be the way that we will proceed with these recommendations. And then hopefully we have, we can aggregate the results and we can start to, we're still receiving a few recommendations. So as everything's being collated, it'll help us start to narrow down some of them. So thank you so much for having that discussion.
So just to clarify, would that be for the next meeting on August 18th? Would we ask subcommittee members to do a preliminary recommendation with everything that's been submitted so far? And then we could use the September meeting, that's the last one we'll have ahead of the full October meeting, to consider any other recommendations that come in.
That's correct, unless if any of the subcommittee members are in disagreement or have any other recommended avenues. Which I don't. Ms. Hale, did you want to say something?
So just to clarify back to your earlier comments about the harm reduction conversation in relation to this weighting process. So you could still identify specific harm reduction recommendations in a priority, but I guess just, keep in mind that there is this decision by the chairs to try to look at that more specifically in 2023, unless the members, decide that they want to do something now. So I think it just needs maybe some teasing out as you're looking at those priorities.
Great. Yep, I agree. Okay. Ms. Johnson, did you want to say something? Yep.
I did have a question about the earlier comment on moving harm reduction. So does that mean that those priorities will not be considered for either bill draft requests or other in the 2023 legislature? Does that mean they'll kind of be tabled?
No. So I think what Ms. Hale was just describing was that it's still included as part of our process right now. So if we determine, based on the policy recommendations that we were receiving, there's still a possibility that that could end up as one of our main recommendations for this report. But if we don't reach that point, because for any reason, if we choose to focus on primary and secondary prevention because we want to push it off to next year, as chairs, we have discussed and set up the opportunity to focus on it more deliberately if need be for the next report. That's I guess that's the clarification. So we still could take on harm reduction and have it included as part of the BDR process if that is a determination that we came to. It's just we're just saying that if it doesn't get the full attention it deserves, and if we start to notice as we're ranking that it diminishes primary and secondary prevention or other tertiary prevention recommendations, that it will get its full attention next year in the next report. That's essentially what we're saying the same thing. Okay. Any other questions or comments regarding this process? We'll go ahead and have committee staff detail it again via email so that we can begin the process of weighting. And then from there on, hopefully we can have better discussions next time once we get the full results from everyone as to what everything comes out to be. So, okay, sounds good. At this point, I just wanna, let's see. And just to make sure, hopefully by the September meeting, that will help us identify which of the different priority areas that we choose to focus on and how everything comes together. So I think that we'll have a better idea once we start weighing them. Okay. Are there any, since we're still on this agenda item, if there's any questions right now on recommendations, I think we can go ahead and take them, but there's any other discussion, I can move on to the next agenda item, which is future subject matter experts or topics. Okay, I don't see any. All right, let's go ahead and move on to the next agenda item, which is agenda item 6, consider subject matter experts for future meetings. I have been receiving a few suggestions from different committee members and from folks of the public on presentations at the August meeting. The ones that I have so far are one from Aaron Russell, who is the chief of the Center for Harm Reduction Services at the Maryland Department of Health. who has been instrumental in the creation and implementation of several statewide programs and policies around overdose prevention and harm reduction. Also have received them from Beth Flamowitz, who is a senior policy advisor on pharmacy at DHHS, who can speak on overdose education and the naloxone distribution. But if there are any other presenters that you would like to hear from based on questions they have from recommendations or topics that they want to learn about, I think this is probably the avenue for it. I did try to structure each of the committee meetings that we have remaining on the tiers of primary, secondary, and tertiary. So today we spent a good amount of time focusing on what NDE is doing and where we can make strides in making improvements. So hopefully within the next following meetings, we'll focus more on secondary and tertiary, that we're giving equal attention to each of them. And then ideally, if there are any gaps in your own education, or if there are things that you would like to learn about more, that's essentially what I would like to ask right now. But if there are any questions or any recommendations, I'll go ahead and open it up. Ms. Johnson, I see you first, and then Debbie.
Yeah, thank you, Chair. I had a quick question. Do you want new speakers, is there anyone? Are you also entertaining if there are folks that have presented before that we want to bring back to talk on other topics?
Both. Either or. Yeah. Ms. Nadler.
I'm going to keep this real short. I would just like to present or have Joe present at the next meeting the Just Say No, the Arts of Communication. It's the school project available for all schools. I've talked with teachers and everybody is all for it. I'm already working with West Tech Academy with 1,500 students. It's a fantastic program and I would like to present it.
Okay. Ms. Nadler, you can use we still have plenty of time remaining before we close this meeting. Did you want to use this moment to talk more as to what some of the work that they're doing? Maybe that's a little bit helpful for us to understand what gaps they're fixing in the infrastructure that NDE left off. Okay. Maybe that if you can give us a little bit of a background.
Long story short, 3 students from a school reached out to me and they said, we need your help. We're working on a project for our school, West Tech Academy. And our principal told us that we don't have a drug problem and we see kids using drugs in the bathroom all the time and we need your help. We came up with a program for them, a billboard competition, which involved their creative minds and which would get everybody thinking, draw us a picture. Whoever came up with the most creative drug prevention poster would go on a billboard. To make a long story short, this turned into a bigger thing because we got Joe's group. Obviously, we know he's got a lot of peers that he works with, the alternative peer group, and we joined forces and created something called Just Say No, the Arts of Communication, where they paint us a picture, tell us a story, sing us a song, write us a poem. Basically, it's for middle school and for high school students. There's 3 different categories. We're giving 3 awards in each school to the top winners of it. And we're also putting them on billboards. As we know, children ages 14 to 18, the fentanyl deaths grew by 169% in 2020. I've spoken with many theater teachers, art teachers, and they are all on board. They are begging for help. They want something. This is to get not only the children involved, the children who know nothing are going to at least pick up a book and look and say, what is fentanyl? What is this? But we're going to involve the families as well. So the kids will be teaching their parents and the parents will be learning. And it's called Just Say No, KNOW, know the facts on drugs. It's not an expensive program to do it all. I've got billboard companies out front who is willing to discount the prices of the billboards for it. It's just going to take for the year, maybe $12,000, maybe at the most to do that. And we've gotten a lot of interest in this, and I would love for the committee to approve this. I mean, this is getting the kids involved. This is hands-on. We have to think outside the box. There's a lot more to it. That's basically the general idea of the program that we're doing.
Yeah, I would, and thank you so much for that. I'll let Jessica say something as well after. But you know, the one thing I would recommend is if there are gaps that the Just Say No program advocates, or if folks in the community are noticing that isn't reflected, for instance, in the curriculum questions that I was asking today, that itself can be addressed in a policy recommendation that can make waves in the infrastructure needs. So I guess what I'm trying to say is, since most of this is focused on the policy part, not really the funding allocation part, what I would like to see is to find those gaps of what is not being delivered in terms of education, and so that we can support a policy that fixes those gaps. So I encourage perhaps reaching out to the community members and see what those gaps are. Let's go to Ms. Johnson and then Senator Gansert right after. So Ms. Johnson.
Yes, thank you for the opportunity. Wanted to respond to that recommendation and then also make a recommendation for secondary prevention presentation, if that's all right. I want to go on the record to be clear that I would have concern about presenting specific programs unless it's presented as like sort of a broad brushstrokes of primary prevention intervention sort of options that are being implemented across the state, to look more at the kind of broad level solutions. Something that was brought up in the presentation today made me think that, you know, it's not all schools have a one size fits all for a particular prevention program. And so what I heard today was that part of this solution is that they're really looking for individual schools to use a set of prevention criteria to determine whether or not a particular curriculum or intervention is the best fit for the students, sort of on that systems level. So I having worked in this for a long time, I do think that really having the opportunity based on the best practices of you know, primary, secondary, tertiary prevention across the board, that allowing districts and schools to select based on that criteria, sort of what meets the needs of the students, teachers, faculty, staff, climate, etc., is really important. And so I would just be concerned or wonder if this committee does entertain a single intervention, that we would perhaps be bombarded with multiple other groups coming in to want to present some of their single interventions. And I wonder if that would contribute to these broader sort of systems level solutions that is my understanding of sort of what the committee is trying to look at. And that's no knock to if Just Say No is the right fit for communities and provides evidence and sort of aligns with the criteria that was outlined by our presenters earlier today for the schools to select, then, you know, that sort of to me is just a different conversation. Thank you. I did have a secondary, oh, sorry, I'll follow up with my recommendation. Go ahead, Senator.
No, you can go ahead. So you said that you had a secondary prevention recommendation.
I did see the statewide coalition partnership presented to us in May, I believe, and did have several secondary prevention recommendations. So I was wondering if that would be an opportunity to follow up to learn more specifically about what those recommendations are from that group. Thank you.
Great. Yep. I will have committee staff and see if they can reach out to them and see if they can come back to present more in detail. Senator Gansert.
Thank you, Chair. So a couple things, you know, I'm not exactly clear on the process of if we're going to have a spreadsheet and we're going to rank things, or we're going to get together the next meeting and we're going to decide what our priorities are jointly. So that's one piece of it. And then the other is maybe we can set aside a pot of funds for small grants for projects like was just presented, the Just Say No, that are small buckets of money, because I think we need to go with systematic changes and sort of like, broadly address the issues that we're facing right now. But I do think there's some creative solutions, little one-offs that we might be able to have a grant program where they can apply for funding for, again, because those are really small dollars for things that will be impactful to certain areas.
Great, thank you so much, Senator Ganser.
And
Emma, did you
can I
want
just-
to? Yep.
Yeah, to your first question, Senator, I believe the other subcommittees have filled out a Survey Monkeys, so we would distribute that to you along with the recommendations tracker. And so that's how we would collect all of your information, and then that would be presented in the next meeting once we compile everybody's top 5 weighted, and then we add all of them up. Does that answer your question?
I think so. So if you're going to use SurveyMonkey, then we have to figure out how to make sure that we understand how to weight something. I don't know if you're going to have a 1 through 5, and then we pick, we rank everything 1 through 5, with 5 being the most critical, and then you compile it that way. Or
I think, Laura, how
are you going to use that tool?
Yeah, so what we did with the treatment and recovery group is the individual members received that survey with all the recommendations, and they had an extra column there for the ranking, and they had their instructions there. So they just put 1, 2, 3, 4, or 5 next to 5 different recommendations. And then those came into me, and I weighted each one. So like a 1 got, 50 points, whereas a 2 got 30 points, just lowering amounts so that you could see the highest scoring combined. So for example, Senator Ganser, your score would be combined with Ms. Johnson's score and weighted according to those rankings, and then you could see collectively what comes out on top. But that divulging that information doesn't happen until the next meeting, again, because of the open meeting law.
So thank you. I appreciate that explanation. And also I think the weighting piece is important, that we understand what that framework looks like. So I've been on committees for contracts and different things, and sometimes the weighting, someone can basically make a 0 weighting for something, which will drive the total score down for an initiative. So it has to be a weighting that makes sense and doesn't allow one or 2 folks who provide input to either make sure something's at the very top or make sure something's at the very bottom. So we have to be really careful about how you weight.
And Laura, just to clarify, it would be they would pick their top 5 and weight within those 5, because I believe we currently have 27 recommendations. It wouldn't be weighting all 27, right?
That's correct. So each member gets to pick 5, and then you can see how those weighed out. In some cases, several members might select the same item, in which case that collective score is significantly higher. And then we present that back to the subcommittee so that you see all of those results, how those came out, how they were scored. And I'd be happy, well, we will send that to members ahead of time so that you will see exactly how that works and how it resolves the issue that Senator Ganser just raised.
Thank you. And we have a number of participants. I'm not sure how many members provide the input. So how many people do we have providing the ranking or the input?
On this subcommittee, you have 5 members. So they are the only ones that will be ranking the recommendations that fall under your purview. And then from that, you will all discuss, okay, you're going to come up with 5 to 7 that you then want to forward to the SURG. And then there's that caveat with harm reduction, where that could be maybe a separate category because it's overarching across the subcommittee. So we didn't want to have disparate hearings, if you will, under the subcommittee, since it cuts across all 3.
Thank you. That's helpful. And then one other question, is there a way, and I don't know how the committee feels about this, is to have a grant bucket for kind of those small projects that can affect, because we're going to have, it sounds like a list of potentially 27 that we get to rank. but I don't know that we've added just the bucket for a certain amount of money for one-off grants. Thank you.
Yeah, I would perhaps, if Ms. Nadler wants to be the committee member, the subcommittee member that recommends that submits that as a policy recommendation, that way we can include it as part of our rankings as we're starting to weigh them. And that would probably address helping the small community groups deliver them. But let's let some of the other committee members, I think there's other questions. Jessica, please proceed.
Yeah, thank you, Senator or Chair Doniate. I wanted to speak specifically to the bucket of funds sort of recommendation. I also am aware that our prevention coalitions across the state do receive block grant dollars, and many of them, particularly the one in Clark County, does a sub-granting process. I believe that it's on a 2 to 3 year interval time frame for community groups to apply for funds to implement programs such as the Boys and Girls Club, such as other community groups across Clark County. So we could have either the statewide coalition partnership could speak to that effort, perhaps at a future meeting, so that folks are aware maybe of the broad range of ways for these programs to roll out. Alternatively, we could add that as a recommendation, but I did want to make sure that the committee was aware that at least for primary prevention programming, that is how some of the block grant dollars are being rolled out in the state. Thank you.
Thank you, Ms. Johnson. Emma, if you would like to our committee staff, probably we can have them quickly present at our next meeting. That way we can get an update from them as to what their process looks like, and that would be helpful. Ms. Nadler, did you have any last minute questions or comments?
Yes, I do. First of all, thank you so much, Senator Gansert, for including this. Jessica, I adore you. I love you. Thank you for everything you're doing. I do have a comment. The bucket list is greatly needed. We do have organizations, especially moms who have lost their loved ones, directly associated with Purdue Pharmaceutical Company. And we are fighting very hard for all our loved ones in the state. We are receiving no money. We're using money out of our own pocket to educate. We can't get grants. We've tried to get everything. Our kids died because of Purdue, the lawsuit money that we're getting. I think it's more than appropriate to have a bucket list such as Heidi Gansert just mentioned for these groups to have some funds to do out of the box things to help the children in our state. So thank you, Senator Gansert.
Thank you so much, Ms. Nadler. Any other last minute comments or questions before we move on? Seeing none, let's go ahead to our next agenda item, which is public comment. So again, I will go ahead and open public comment, which will be limited to 3 minutes each per person. Members of the public may comment on any matter that is not specified, including on the agenda at this time. However, no action may be taken upon a matter raised under this item of the agenda until the matter itself has been specifically included on the agenda. So if there is anyone on the Zoom call that would like to raise their hand for public comment, now would be the time to do so.
I see Ms. Johnson has her hand raised.
Ms. Johnson, please proceed.
Thank you so much, Chair Doniate. I wanted to make this committee and attendees aware of 2 events that are happening in Southern Nevada in the month of August as part of public comment. So the first one is happening on August 10th. It is the Southern Nevada Substance Misuse and Overdose Prevention Summit. It starts at 8 a.m. It's a hybrid meeting. So happening at the Marriott Renaissance in person and also online. The topic is on fentanyl and fentanyl overdose. So very relevant to this committee and the work. The website to sign up, I will say it, and then I can also send it to staff so that folks can have that resource, is snhd.info/SNSMOPS22. There's also scholarships available. There's a small fee to attend, but there's unlimited scholarships available for anyone who would like to attend. So that's the first event. The second event is happening on August 31st, International Overdose Awareness Day. The celebration in Southern Nevada will be from 5 to 7:30 p.m. at the Chuck Minker Sports Complex. Individuals interested in attending can sign up at nvoverdoseday.com. Thank you.
Thank you, Ms. Johnson. Emma, is there anyone else that would like to provide public comment?
I thought I saw a hand raised, but it looks like it went down. All right, I see Miss Nadler has her hand raised.
Ms.
I'm sorry.
Nadler, please proceed.
Last time I'm going to speak. Yes, we are also having an event on August 30th. It's International Overdose Awareness and Memorial Day. We're having it at the Vegas Sign at 7:30 p.m. I myself pay to have the lights lit up purple in honor of all those that we've lost. So the event is at 7:30. It's open to all. We'll have the banners up of all our lost children, and it's a memorial for all of them. So it's open to the public, 7:30 at the Las Vegas Sign. Thank you.
Thank you, Ms. Nadler, and of course for your advocacy. It's very much well appreciated. Any other public comments at this time? I don't see many. I don't see any. So let's go ahead and move on to our last agenda item, which is adjournment. So I'll go ahead and end this meeting. We have our next one scheduled for next month, and hopefully we'll have further discussions on the weighting of policies. So thank you so much to our committee members and to NDE for presenting today. The meeting is officially adjourned. Thank you so much.
Thank you. You're awesome. Thank you.